All right, thank you very much. First of all, there will be materials I'm going to show you that are available to you. This talk, at times, versions of it I've done for communities and for other entities can go quite a while. So I'm going to be talking very fast, and it's going to feel like you're drinking from a fire hose. And I apologize for that at the front end, but I'm trying to help you. I'm trying to get you all the information I can in the time we have, and there are resources available that are going to help you through that. Okay, so here we go. We're going to talk about the disclaimers, which I always have to do about things when I talk, and I always want to say, don't hold me to it. I always want to give thanks to some of the organizations I work with and some of the people I write the research articles with. I never want to forget some of my boys. So these are 3 of them, and why I work so hard. Call, but in particular, the State Bar and also the medical organizations require that I give you my conflicts of interest. So I'm going to run through those very quickly, and those happen to do with the books I've written for the AMA. So the AMA Guides Causation book. Causation is a central feature of workers' compensation. I'm sure you all know about that. That's why that's important. Next book is the Workability Return to Work book. There are some comments in today's talk that come out of that book. And so again, that's a conflict of interest. We did the 6th edition. I know we are a 5th edition state, but once again, you can resource any medical textbook in defending your cases. And so that includes the 6th edition. And then finally, for people that are relatively new to workers' compensation, short-term disability, long-term disability, Social Security, any of those kinds of symptoms, we have a book that we wrote, and again, that's for people's general benefit. Many of my comments come from the national guideline that we wrote. So this is the ACOM national guideline. The most current version is the June 12th version. And if you want to get the most updated version, what you do is go here to mdguidelines.com, mdguidelines.com right there, and then it's available in front, meaning that you don't have to have a subscription or pay for it. Because of the coronavirus, we were able to put it out in front so people can have direct access to our guideline if they need it. Also, there's another article that we published in Tennessee. Tennessee is part of an 8-state consortium that puts together different information from different sources and is used in their decision making. So this is the article on rating survivors of COVID-19 for permanent impairment, which is very applicable. We have another paper that got accepted for publication in the Journal of Occupational Environmental Medicine that should be available online probably in a week or 2. Published version will be coming out later that will also have more information about how to rate survivors of this, okay? All right, so let's go through some of the medicine so that we all have a similar idea of what we're talking about here, okay? First, virology. So SARS-CoV-2 is a beta coronavirus, and I want you to know something here. There are 7 known RNA viruses that infect humans. 10 to 30% of the common colds are due to coronavirus. So by odds, all of you at one point in your life have had a coronavirus infection. All of you have some memory in your immune systems to this type of infection, right? It's called corona because it looks like the sun under a microscope. And what we use the term SARS stands for Severe Acute Respiratory Syndrome. MERS, which is a distantly related coronavirus cousin, is also sometimes talked about. And both the SARS, the original one, which is in 03, and our current SARS, which is why it's called number 2, jumped from horseshoe bats. Both started in China, both started in the same kind of Wuhan area. Those bats are not endemic to where it started, which is why there's all the discussion about, well, you got this research lab and you're working with these viruses, so how did it get out of here? And that's why you heard all that kind of stuff. The SARS outbreak in 03 and 04 lasted 9 months, okay? There were 10% mortality, right? The MERS, which is an epidemic, right? Which means that it never became a pandemic, had a 35 to 40% mortality, right? So I want you to keep those numbers in mind. But we're talking about mortality rates. We're talking about this condition to give you some perspective on what we're dealing with, okay? Next, here's a model of what this looks like. And a more simple model is this. I want to show you this. Look. E protein, S protein, M protein, nucleotide. Those are the parts of the virus. E stands for envelope, S is spike, M membrane. Right? What do those have to do? Those are the targets for the vaccines. Those are the targets for the testing. That's why those are so important for us to remember, okay? All right, social distancing, 2 different periods of time. All right, next, epidemiology, okay? This is primarily spread by respiratory droplets, okay? Those are the things from coughing and sneezing. A droplet goes about 2 to 3 feet. It doesn't go 6 feet. It doesn't go 10 feet. That is why, by the way, the World Health Organization has as its standard 1 meter of distancing because it covers the vast majority of droplets. There is less aerosol. So aerosol is when you have a very fine particle that floats up into the air, right? That aerosol, that fine particle, is something that could potentially cause trouble, but is rare in this condition. So there's some reports of people being in choirs. They're standing next to each other. They're singing next to each other. They're doing everything they can to try to have that experience going of singing together. And what happens is in that sitting, you could get some aerosol. What we worry about most of it is when we're dealing in the medical world. That's more our world, when you're doing procedures on patients like bronchoscopy and stuff, that's where you're going to get more aerosol. But look at the difference here, right? Measles, everybody knows about measles, right? You always heard when you were a kid, we're going to have a measles party, or I went to a measles party or something like that, and everybody got sick, right? Why? Because measles is an aerosol. It's something that floats up in the air easily. It has very high attack rates. 85, 90% of people, if you're in a room with people, are going to get it, right? Corona in healthcare workers. People are surrounded by the aerosols all the time. Maybe you get 10%. And in households, aerosol, less than 1%, which is why I have patients that have said, you know, I got sick and my family was around me before I knew I was sick, and all of a sudden I'm sick, but they never got sick. Why? Because the vast majority of spread is through droplets. It's not through aerosol. Keep that in mind when people are telling you about distancing issues, right? Another thing that you can look at is how quickly these things fall to the floor. So tiny little micron particles drop like rockets in general, right? Now the SARS by itself is a small particle, right? You should say, okay, it should be suspended indefinitely. Well, that's true if you've got it all by itself, but most of these come in droplets. That's why they drop down. The other thing is UV light kills all viruses, right? So that's why, by the way, in this time I say all my patients, get outside, right? All this stuff about staying home, isolating stuff, it messes with everybody. It messes with your diet, it messes with your exercise, it messes with your sleep. You lose your circadian rhythms. Get outside, and if anything, it's a better place to be because the UV light is going to kill off the viruses all around you, okay? Incubation period. Next, 5 to 6 days. Now you're going to hear say, oh, I heard it can go on for, okay, look, anything is possible. Let's talk about reality. Reality is it's about 5 to 6 days. So a lot of times what I'm doing right now with my patients is they say, look, I want to go back east, see my parents, stuff like that. What would be reasonable? So I say to people, look, if you want to be reasonable after travel, give yourself a week if you're going to be seeing somebody that you think might be more susceptible to trouble, right? So if you could, give yourself a week, but at least 5, 6 days, and you've gone through the vast majority of incubation period that's possible. Next, very important concept. The virus sheds 24 to 48 hours before symptom onset. Before you know you're sick, you're shedding this virus, okay? The viral shedding usually is no more than 3 days after symptom onset. Now they're gonna say, well, I saw these studies. And they say, well, we could find these viruses for weeks and weeks and weeks after symptom onset. That's true, you could, but those viral particles are not necessarily infectious, right? We always do this with other viral infections. We're left with residual pieces. So that if you go and put a Q-tip in there and test for it, you're gonna pick up some of those proteins, but they're not necessarily infectious. They're not necessarily going to cause trouble for you. And keep in mind, the majority of people who have this infection will have no or mild symptoms. Look, just one study, just example, one study. Pregnant women are watching themselves regularly. They're isolating themselves. They're going to the doctor's ready to make sure they're staying healthy. They go into the hospital, right? They're ready to deliver the baby. They've had no symptoms, right? And when they tested these, 70 to 80% of the pregnant women who tested positive never had symptoms, right? That's normal. That's going to be the majority of people. That's why when you see all the more worrisome stuff, which is worrisome, it is a problem, right? You have to keep this in mind, right? And next, people always talk about reinfection. They said, well, I heard this report that somebody had, look, this is almost never going to happen. anything is possible, but it's probably not going to happen. First of all, the studies, there is no human reinfection that has ever been confirmed as of now, ever. This includes all the things you read on the internet and all these things. When they go through and study people and look at what happened, no reinfection has ever been seen. Why? One, because those people that are mild or asymptomatic, right, maybe didn't know they had it at first and didn't realize that it was operating there. Two, those people that are mild or asymptomatic, there's something about their immune system. They're younger, they're healthier, whatever, and so they're not going to have much in the way of difficulty either now or again, right? Because there's something about them that protects them, right? It's more likely that if somebody has something they tested later, then what you're testing for is something that just never went away, right? I've already told you that you can put a Q-tip in that nose, you can see some viral particles, you're going to see some leftover particles, but they're not infectious. They're not going to be something that's going to cause trouble for you. By the way, let's look at an example. Influenza, the flu, right? So influenza mutates about 50 times per year, which means that's why I always say to everybody, you got to get your flu shot. And all the lawyers know that are in this area that there's two types of lawyers in Los Angeles. Those who will come to take my deposition between August and January, and those who refuse to come during August and January, because everybody knows the rule in my office. If you come to my office for a deposition, I will give you a flu shot whether you ask for it or not. And so there's two types of lawyers in the world. There's one flu shots, one that don't. And so it's important. Why do we give it every year? Because it mutates a little bit. But if you look at the flu shots, if you look at them carefully, the actual substance in there, most of it doesn't change year to year because the flu doesn't change that much. Corona mutates about 25 times per year, right? So that means that if it's going to change much more slowly, which means that if you get the infection, you're not going to have a problem with getting reinfected. You're not going to be susceptible again. You are going to be immune, right? That's the medical reality. That's what we've seen in every virus in history, right? All right, now, surfaces. People talk about, well, I heard about touching things. First of all, the CDC has a very clear statement, which I'm glad that they finally made a clear statement about this, which is that transmission through touching objects is almost impossible for you to get the infection, okay? Why? Because first of all, what happens is the viruses don't last very long outside of the body and outside of dried out droplets. Two, you have to envision that somebody who's very ill comes and delivers a package to you or touches something where they hack and cough a huge chunk of watery droplets on it, and then you come by and swipe your hand along that, pick it up and smash it all over your face, right? Okay, it's just not going to happen like that. It's extremely rare, and so that's why we don't see that as a very common mechanism of transfer, right? Now, there's a study that people cite a lot. This is an aerosolized gas, okay? What this means is somebody rears back, takes a huge cough and sneeze, and woof, out in the air goes all the air, and you see this measure, look at it, 7 to 8 meters, right? But that 7 to 8 meters includes somebody that's large, a large volume, and also that you got some wind coming along. So is it possible that you could have viral particles that aerosolize and go up? Yes, it's possible. But the vast majority are within water. The vast majority drop out quickly. The vast majority, by the time it gets into this fine mist, is not on a high enough concentration to cause illness, okay? Now, look at this slide. This is a little busy, but stay with me. Stay with me. Look at the top here. Look, we're looking at aerosol. So here's copper, cardboard, stainless steel, plastic, right? And we both the SARS, the first one from 03 and this current one. And look how quickly you see the drop off of these large live viral particles, right? It drops off quickly. And by the way, these are in logs, right? Which means, remember, that's a statistic about how big the concentrations are. So you can see how quickly this stuff drops off on the surfaces, why in general, surfaces are not a major issue, right? Now, contagiousness. This is also called the R naught, which is the reproduction rate. Current estimates are that this is at 2.5%, which means for every person that gets this infection, on average, they will infect 2 to 3 people. By comparison, the flu is about 1.3. So you can see that if you can start doing some mitigation, that you can get that rate down below 1. And when that happens, the spread will end, okay? Now, predictions. So you heard all these predictions. Oh my God, there's going to be millions and millions, and New York's going to need 300,000, this, and they're going to need 30,000 ventilators. Look, I wish I could have been betting in Vegas on some of this stuff because I already knew this stuff. First of all, the Imperial College Ferguson's work, they do all the modeling assumptions that everybody uses, but the problem is these guys have been wrong before, right? Remember about mad cow disease? It said everybody in the world is going to get mad cow disease, and so I'm going to go after, cull the entire herd of the United States. It's just not true, right? It's not true because they have assumptions that don't operate, and what they do is they put in these assumptions that are not realistic or necessarily holding up. Why? Individuals will vary in their susceptibility. Not everybody has the same susceptibility. Why do you see 70–80% of people with minimal no symptoms? Because people vary, right? And so there's something called the herd immunity, the HIP, which is a formula that we use. And so what that means is that depending on how infectious someone can be, it will dictate how much of the population you have to have in order to help stop this thing, right? And so it turns out that you'll hear numbers like 60, 70%. Well, it turns out that the true number to reach HIT may be as low as 15%, right? It may be much less because of other things that we're doing, right? And also, don't forget, when they're doing the predictions, they're doing all the deaths, 40 to 50% of the deaths come from nursing homes, right? Not applicable to the vast majority of our population, of the working population, okay? Now, next slide, a little busy. I just want to walk you through this just so you have an appreciation of this stuff, right? So take a look here. Look. This is deaths per million at 21 days versus days of shutdown. So what that means is that you should see those people that shut down fast as having much less infections, and those people that shut down much later or not at all would have way more infections, right? So this curve should go up like this, but it doesn't do that, right? So you see it's a relatively flat statistical line, which means that all the stuff about shutting down the world and shutting down the economy and stuff like that, it's just not necessarily true, right? It doesn't necessarily cause the impact that you think it's causing, right? Now, there's stuff that we have on influenza throughout the years. It goes up, it goes down. It shifts a little bit this way, it shifts a little bit that way. Some mitigation helps, some changes some of the numbers, but that's the kinds of things you keep in mind when you look at this data. Now, on the medical side, listen, in our world, it's fantastic. You shut down a whole world and stuff, it gives the doctors lots of time to kind of think about things and think about studies and think about treatments and study it and stuff. So that's great, but it doesn't come without a cost, right? And what is that cost? So if you look at our book on workability and return to work, the first chapter is about what happens when you take our brothers and sisters that are on the lower levels of our society, the types of clients that most of you represent. What happens to those people? What happens is you take away their jobs, you take away their income, every health indicator gets worse. Increased rates of suicide, depression, marital violence, divorce, hypertension, heart attacks, everything gets worse, right? It comes at a cost. You don't get something for nothing, which is why I get very animated about these discussions about shutting down, right? So I see both sides of it, but I don't think everybody hears both sides of it, which is what's very important to know about the epidemiology. Okay, so it's a rest stop. All right, now what we're going to do is we're going to talk about clinical features, okay? So here we go, right? Okay, who gets this, right? So look at this, look. Age greater than 65 accounts for 80% of deaths, and look at this. The median age for death is 80, okay? So that's why these things get shunted so much by the nursing homes and the facilities, right? I mean, New York had this as nonsense where they take people, they're in the hospital, and they forced all the nursing homes to take them back in for recuperation, which is the dumbest thing ever, right? Because that's the most vulnerable population, right? That's not good, right? But if you are over 65 and you're in good health, you have about 90% chance that you'll have no or mild symptoms, right? You have to know that, right? Who's at risk? These are some of the people at risk. There's a recent study in New England Journal about a genetic mutation puts you at risk. There was some discussion about BCG vaccines helping you, and that's probably not true. And so that's why you have to think about it. What symptoms do people get? So here's the common breakdown of symptoms. Here's the percentages of which they usually get it. And it gives you an idea of what things that people will talk about. In particular, anosmia, that's the loss of smell. It's a very common one that is very helpful for us. Okay, so we're talking about clinical features. So the question is, how do we approach this? Okay, so look, there's 6 types. So here's the 6 types of clinical features, right? The asymptomatics, the mild, the pre-symptomatics, the upper respiratory, and then you get down here, the lower respiratory, the ARDS. That's the more worrisome stuff, okay? That's the ones that are the hospitals. Those are the ones we have to keep our eyes on for, right? Also, don't forget, there's good data that there's co-infection, right? Which means that, independent of the study, there was anywhere from 2 to 20% of people with coronavirus had other things, right? Which is why when you say, well, I heard that if you take a zithromycin and a Z-Pak, it helps you. Well, one of the reasons it was helping some people is because they were co-infected with bacteria. It had nothing to do with the benefits of the coronavirus per se, right? Influenza is another common concern of co-infection, right? And so that's why, for example, one of the tests that's come out right now is going to allow you to test for both of these things at the same time, both influenza and coronavirus, right? So that's something also to keep in mind, right? Pneumonia is generally viral, no antibiotics, the anti-inflammatories, but here's the thing I want you to know. The most worrisome is this ARDS, which stands for acute respiratory distress syndrome, okay? That's the one that we worry about. And I want you to keep one thing in mind, This other stuff, the DAD and Hyman, that's the stuff for the doctors, just ignore that for a second. But look, HIT, it's 4 to 7 days. Here's what's important. I see a patient. They have a feeling of fatigue, low-grade fever, a loss of smell, and they were exposed and say, okay, look, I think you got the coronavirus. I want you to go home, right? And just check your temperature. Make sure you don't feel too sure about it. But the key is usually at days 4 to 7, because days 4 to 7 is that period of time where after somebody gets sick, if they start having high fevers, if they start having shortness of breath, that's the emergency group. That's that small proportion of people that are ones that are going to go in the hospital and going to have troubles. Now, this is not just your lungs, right? ARDS, right, not just hits the lungs, it hits the brain. It hits your muscles. About 50% of people with severe ARDS are out of work at 1 year, right? ARDS also hits the heart. You can get Guillain-Barré, you can get PTSD, right? And so those are the kinds of things that we think about when they get the more severe infections. Okay, so that's the rest up. And now what we're going to do is we're going to talk about testing. Testing is very important for you to know about and keep it straight, okay? So the number one question, people say, I got tested. The number one question is, which test did you have? Was it a nasal smear or was it a blood test? Nasal smear or blood test? The nasal smear is for live virus. The blood test is for the antibodies, okay? So here's the nasal smear, right? You're looking for live antigen, right? This is the one that goes all the way back in your nose. Remember we talked about viral shedding 24 or 48 hours before. By the way, the virus peaks at about day 1 and starts dropping off of there. It's usually gone by 12 days, right? So again, people say, well, I heard that 6 weeks or something. I told you, right? Anything is possible, but the vast majority of people are not going to have that. It's going to drop off quickly, right? You got reasonable sensitivity and specificity for picking up, but mind you, it starts dropping. Days 8 to 14, your recovery rates are going less, right? One thing you can do to compensate for that is do multiple tests, but who wants to have the thing stuck in their face? But nonetheless, you can do that, right? You could say, I'm going to do it through the lungs because that's where the virus really sits. That's where the severe infections. Yeah, you could, but you got trouble. Because if you're going to start saying to every patient, look, I want you to hack and cough, you're going to start aerosolizing into doctors' offices, into rooms. You're going to have other patients, and that's going to create more infectious troubles than you want. That's why we usually don't do it, okay? Next, if you're doing the blood, right? This is currently 2 of them. There's the pinprick, which is a reasonable test that looks at the antibodies. There's also now coming online the ELISA. The ELISA is a more reliable test, right? So if you think somebody's got it and their tests are not turning positive, one of the things could be that you need to do an ELISA test, not just the pinprick, but they both have their place, okay? So now don't roll your eyes at me at this slide, okay? It's just, I know you said, Mark, I didn't do this. I went to law school. Don't bother me with this. I forgot this in high school. Just please bear with me because it just helps you understand the medicine so you'll be better at this, okay? So the antigens come in. That's the virus. You got a macrophage. It kicks out a response, goes to the T cells. The T cells say, okay, look, we're going to help kill this thing, and we're going to also help the B cells, and we're going to also help produce antibodies, right? So that's a whole process. So look what's involved here. Look. You got T cells, you got B cells, you got antibodies. That's why it's not just antibodies that are going to protect you. Now, this gets a little busy for you, but it's a very important study. Very important. Look. If you had the SARS, the COVID-19, right? They did a test on this. And people with mild disease, 100% had T cells, 100% had IgG antibodies, not 99, not 95, not 90. So people say, well, I heard you get this infection, and then you don't know that you're protected. Look, all right, we've only had it since November. Anything is possible, but every single virus in the world behaves this way. The past SARS behaves this way. The MERS behaves this way. Why are you going to tell me that this is going to behave any differently? It's not going to behave differently. You're going to get protection. You're either going to get it from the cells or the antibodies, right? And patients who have never had exposure. Now, this is very interesting. Look. From 2015, they had one study done where they had patients who were in another study that were doing something else. They took their frozen blood, they tested them to see if they had antibodies for coronavirus, and 50% had antibodies. You're gonna say, that's impossible. The thing just started in November, right? But remember, I told you that there's already other coronaviruses. There are coronaviruses causing common cold. There's ones that are much simpler. So that could also explain why some people will get exposed and have mild reactions because they already have some of the antibodies. By the way, look at this. There are 2 patients now documented with a rare condition called agammaglobulinemia. Can forget about that. What it means is these patients cannot make antibodies. They both got coronavirus. They both recovered. You don't even need antibodies to necessarily get over this thing, right? That's why you're going to know that if people get this, you're going to be protected, okay? The blood test. The blood tests look for antibodies. Now look. These are some data about the dates, but I just want to keep one thing in mind. What I do with my patients is that when they have symptoms and they want to mark, do I have the antibodies or something, I usually ask patients to wait at least 2 to 3 weeks because it takes a time for these things to get up. By the way, look at this. The 2003 SARS, the IgG antibody lasted at least 2 years. The MERS in 2012 lasted at least 3 years, right? So we've got data about how long these things will last, right? This is a busy slide. I don't want to confuse it too much, but what it is I just want to highlight one particular thing. Every test in medicine requires interpretation, which means there's no perfect test. There will never be a perfect test. Every test requires a doctor's interpretation. This is the history of medicine. It will always be the case. So if you have the chances of an infection that's very low, it doesn't matter how good your test is. Your post-test probability is still going to be low, right? Everything requires an interpretation, right? Now, this is a different way to look at this stuff. So I just want to make it some people process better, okay? You're exposed to the virus. You don't have symptoms until you're, which is something nothing. But during that week before, if you're really studying people carefully, you can start seeing those antibodies not coming in yet, but here's all the antigens, right? Here's all the viral particles, right? You see that peak right after you start having symptoms. And then those start dropping down. Oh, but here comes our antibodies, right? And those are coming up. And that's when you see the IgG, which goes on for a long period of time. So that's what's happening in your body, okay? So I can guarantee you little things. Huge numbers have had this and don't know it. One study in a city in Italy, 46% of people had the virus, didn't even know it, and that's it. The current range estimate for fatalities is 0.2 to 0.4%. Now I want you to hear that number, because even in some of the hysteria where they say, oh my God, everybody's dying and something like that, even there they're starting to say, okay, well maybe it's not as much as we thought, maybe it's 5% or something like that. Flu is 0.1, okay? So this may be about the same flu. I think it might be a little bit more than flu, but it's not like the other ones. Remember I showed you that data before? You know, the first SARS had 10%. The MERS had 35-40%. By the way, MERS was an epidemic. It was not a pandemic. Why? Because it killed so many people so quickly, it couldn't even spread, right? The other SARS was much more effective. That's why it didn't last very long, right? And so this one, you're going to see as you get more and more testing done. So every day you pick up the newspaper and say, oh my God, the virus accelerated. Okay, look, there's multiple issues there. One, there were already patients. I had lots of patients in my practice that I knew had this condition. And I knew that they had it and they didn't want to go get tested, right? This is not available. I'm already infected. It's not going to make a difference, right? So I already knew that there's a lot of people carrying this, right? Now, it is going to spread. There's no question about it. There's going to be more people as you open up. There's no question. I'm not sure it's always a bad thing, because as you get more people, it's going to help stop the spread. So keep that in mind, okay? So we've talked about that information. I'm just going to talk very, very briefly about treatment, just to have a few little points about that, just so you've got the ideas of treatment. This is a little schematic, shows you where all the treatment is focused on, about the different stages of viral replication and how it could help. But it's 2 things. One, anti-inflammatories. You may have heard where people say, oh, I heard if you take anti-inflammatories, it's going to make you worse. And it's going to make it, look, it's anecdotal, not true. 4 studies show no effect. But if you really want to do something about it, you can take Tylenol only. By the way, one more thing. I tell all my patients, right? If you're sick, you should take Tylenol, and I'm totally fine with it. I want you to know something. If you take high doses of Tylenol, if you take high doses of anti-inflammatories, you are putting yourself in a position where you could suppress your immune system, right? You just have to think about You know, God made us a certain way that we generate a fever and all that kind of stuff. And there's a reason for that. That's part of how we respond. Okay, next, the ACE2 receptors. These are the receptors that the coronavirus binds to. It happens to be one of the targets for blood pressure medications. And people say, oh my God, if you're on blood pressure, not true. It's not been shown at all. Stay on the blood pressure medications. You're totally safe. We talked about the sunlight. We talked about the Z-Pack. That's very important. That's a brief rest stop. Okay, next, I want to show you the impairment considerations, okay? So these are the questions that I want you to be using on your intakes. These are the questions that you should be thinking about when you're looking at a report from a doctor that's evaluating this, right? When one of your internal medicine doctors does this kind of stuff, take a look. These are the kind of things you want to hear about, right? And in particular, we have the California presumptions, right, which also come into play. Those are questions that also have to be looked at and talked about when you're doing this. One of the things you want to look at is, were there any of these pre-existing conditions, right, that put somebody at risk? Sometimes that might have an impact on how you decide about apportionment, right? So what this generates is some clinical scenarios. So this is just like what you're going to see in the AMA guides and the other books. So I'm just going to run through these very quickly, right? So you can have an asymptomatic individual, doesn't have any specific troubles, and people with subclinical infection. These people you can call MMI right away, and there is no permanent impairment ever in the literature for something like that. Somebody who's pre-symptomatic, right? You're going to have to wait and see what happens with them over time, right? So you have somebody who's tested positive and has mild disease. Again, the literature says there are currently no case reports of individuals with mild disease who recovered home and have any persistent impairment, right? And that's what you'd expect, right? These are viral infections. These are simple viral infections. What you'd expect is for the vast majority of people, they're going to be mild with no symptoms, they're going to recover quickly, and they're not going to have any permanent impairment. That's the vast majority for sure, right? Number 4, now you start getting to moderate disease. Now these are the people going to the hospitals. Now you got to start doing some homework. You got to get the medical records. You got to see what's going on. They can be more severe, right? Where they're in the ICU. Now you start making sure that you've got some testing on these people. PFT, metabolic stress echo, those are the gold standards for looking at this. And you may have to wait a while to declare MMI. The worst ones, dinner 6, those are the ones that got all the associated things. There's these problems that can be in the heart, in the psychological, in the coagulopathy with this clotting, right? Now you're going to have to do a lot of testing, and you may have to wait months to years in order to consider these people at maximum medical improvement, right? This is
Doctor. Sorry, this is a friendly 5-minute warning. It's 10:20.
I'm almost there. I'm almost there. Yeah. I'm going as fast as you can. Okay. So this was published by Kyle once before many years ago. This is my activity daily living questionnaire. You can use any one. It's just a reminder that anybody that has these conditions, you really should be looking at all areas of impact. These are the kind of standing of testing. If you look at the AMA guides, there is ways to rate all this stuff, all the complications of coronavirus, right? So we're a 5th edition state. When I lecture the other states, it's different. So in the 5th edition states, here's all the ones that you use for the cardiovascular complications, the lung complication, neurology, ENT. By the way, if people have persistent anosmia, loss of smell, there is a way to rate that in the guide's 5th edition. Of the hypercoagulable states, the mental behavior. Now, this is some important data. This is from the MD guidelines. Just want to show you, look. This is 6,000 cases, right? So I actually am a medical editor for them. And so what we did is looked at all the cases that have been reported so far and look at the disability durations on all these cases, right? So in general, that's what you're going to see. For the vast majority of people, it's going to be 2 to 3 weeks, and then that's it. They're going to be back to work. Okay, those are the boys. One last thing, just for your own information, for a little bit of fun, and I'm Thomas Jason. I'm down. This is masks, right? So just remember, when you're wearing a surgical mask, when you're wearing a bandana, you're trying not to give an infection. If you want to be protected, you have to wear an N95 mask. That's the only way you're going to be protected. This is a nice little grid that shows you that in our world, the medical world, way up here, then you're going to need these high quality masks. But if you're walking outside alone or you're just by yourself or with your family member, you don't need a mask, right? You start to have little covering needs depending on if you're going to be around more crowds and more people, right? Okay, so diet, exercise, weight loss is important for all things, but in particular for keeping things regularly. There's no better time to make sure you have a relationship with your regular family doctor who interprets tests for you. Don't forget to get a flu shot every fall. If you say, I'm wearing a mask, but I don't get a flu shot, I don't know what you're thinking. Get the vaccine if we ever develop one. By the way, the administration came out with some very good and unique things. I would say to all my patients, it's usually going to be first quarter next year, but the administration and their coronavirus task force came out with a very interesting thing what they're doing is right now they're paying all the companies who are developing vaccines to also mass produce them. And they're going to pay them to mass produce even if we never use the vaccines, and that will cut down the distribution time. We talked about the fasting, talked about it. Prayer is very important, don't forget that. And that's it. I'm done, and that's as fast as I can possibly talk as a human being.